to the National Headache Foundation Cervicogenic Headache webinar. Today we are joined by Dr. Wade Cooper. Dr. Cooper is the assistant professor at University of Michigan's Department of Neurology and Anesthesiology. Dr. Cooper has served as a medical reviewer for several pain journals and has published multiple articles focusing on diagnosis and treatment of headache and pain syndromes. His current clinical research focus is inflammatory markers in migraine, vitamin deficiencies and migraine, and cervical spine pain and its association to chronic headache. Dr. Cooper is also serving as the program director for the Headache Medicine Fellowship Program. Dr. Cooper, thank you for joining us.
Fantastic topic to cover tonight, and that focuses on cervicogenic headache, and many times that's related to post-traumatic headache. And we'll be able to run through some slides talking about basic anatomy of the neck, talking about what is migraine and what is chronic headache and how does that relate to neck and neck structures, and also talk about treatment options and ways you can interact best with your clinicians, your providers, to find treatment solutions if you have a neck-related headache disorder. I know that those listening have kind of a varied background, so what I'm going to cover is relatively general to start, and I'm hopeful that we'll be able to investigate and go into several questions towards the end to really amplify our understanding and amplify what you get out of today's webinar. So before we even move forward and talk about the neck, it's important to understand and appreciate how migraine pain is felt in the head and headache is felt in the head. And it turns out that there are lots of pain-sensitive structures. A lot of times, you and your doctor, you and your provider will talk about trigeminal pain, which is a very funny-sounding name. But the trigeminal nerves are the nerves that provide all the pain sensation to the surface of the brain. That gooey-looking picture I've got in the front of that screen there is really the brain itself, and all those small little spidery things coming forwards that are in that lightish brown color, those all represent nerves in the brain. And the way the pain sensation set up for the brain and also for the neck is that these pain fibers come from the center portions of the brain and they kind of spiderweb around the linings of the brain. With those listening in, you may be familiar with meningitis, and that's where someone gets sick and they get a virus or they get a bacteria that is in the lining of the brain, something we call the meninges. And that lining of the brain, when it's inflamed and painful, it gives people severe headache as well as chills and sweats. But what's interesting is even meningitis turns on features of migraine, which is light and sound sensitivity and nausea and throwing up. So people who have an infection of the lining of the brain can have this really severe headache, and they have a high temperature and they look really sick, but they also have all the markings of migraine, which is light and sound sensitivity and nausea and, of course, the persistent headache. We also know that the nerve bundle that controls migraine actually goes down the neck. And I've got some pictures that show this on this next slide. So here is really a picture of the head itself. First in yellow are those nerves I was mentioning called the trigeminal nerves. And then what I've got in that light blue color that goes around the front of the brain are the nerves of the trigeminal nerves that provide pain to the lining of the brain. The next piece of that picture I want you to look at is towards the back of the head and towards the neck. And that's that purplish structure that goes down towards the neck, that little purple line that's been drawn on there. That's the nerves of migraine that go down into the neck. And then that orange arrow that kind of starts at the base of the neck and wraps around the back of the head, those are the nerves called the occipital nerves. And there's actually several pieces to them, but really just to look at them as the occipital nerves. And those provide pain to the back scalp of the head, and they also provide pain to the lining of the brain that's in the back of the skull. So what's interesting about this is if people irritate the neck, and you can imagine if that orange line is irritated, that gives people a lot of pain in the back of the head. It also gives people pain in the neck, typically on one side or the other, and that can turn on or bring out chronic migraine. One of the things that we know about neck-related headache disorders is that they're more common in people who've had history of migraine before. So if someone's had migraine before, that means their brain is more likely to generate migraine than people who don't get migraine. And therefore, if you irritate that nerve bundle that goes down the neck that's part of migraine, called the trigeminal nucleus, If you irritate that from a neck problem, that'll bring out more headache. So a common description of this is someone who says, I've had episodic migraine for most of my life, and then say at age 30, age 35, maybe even later, they get into a car accident or they have a physical assault, and then they develop a new feature to their headache. They typically have persistent or worsening of their migraine headaches, and they develop some background neck achiness that's present there almost all the time. And in that situation, you would want to consider the idea of the neck structures being irritated enough that they're bringing out or they're inducing chronic migraine in somebody. And the treatment tools for that are a bit different than they are if someone has just plain migraine. So this picture really just kind of shows you the anatomy, how those nerves are tied together. Just to summarize, you've got the nerves in the front of the head, that's those yellow ones, and that's the blue ones that wrap the lining of the brain. That's the typical migraine areas of the body. Then you've got the deep brain areas, that's that kind of blue, and it turns into a purple line that comes down the center of the brain where it's nice and bright on this picture. Then you've got the nerves up from the top half of the neck that make the pain fibers up the back of the head, which are all neck-related structures. That's called the occipital nerves. And those are the ones that are part of neck-related migraine or cervicogenic headache. So let's look at this next picture here. And this really shows, before my picture got put on top of that, this shows a bell-shaped curve. And what this is meant to show is that if you take normal pain stimulus, and these are people who don't have migraine, these are people who don't have any other pain syndrome, and if you apply a pain stimulus, and this research that was done, it was using a thumbnail pressure to when someone says, ow, that hurts, it turns out that people with no migraine history are typically varied in their pain response. Some people can say, wow, a little bit of pain to my thumbnail is very uncomfortable very quickly. Other people try a whole lot of pressure to their nail bed before it's painful. And what's interesting is that those people who are more sensitive to pain in general are more likely to go into chronic headache after something like a head trauma or a neck trauma than people who aren't as pain sensitive. So in this guy who's actually falling off his motorcycle and about to have some badness to his neck happen, if he's someone who's prone to be pain sensitive in the first place, and he injures his neck, he's way more likely to develop a neck-related headache syndrome than someone who isn't as pain sensitive in the first place before an injury. So this kind of brings up this concept. For people who have post-traumatic headache, we know that the head or neck trauma itself, the degree of injury, is not that important. And this is kind of a complicated slide, but this just shows that the only real predictor of someone having post-traumatic headache or cervicogenic headache, that means neck-related headache disorder, are those people who are prone to have migraine in the first place. So if someone's not prone to have migraine, and they have what's happening in that picture with the gentleman falling off his bike, and their neck is extended all the way back, and they irritate those structures in the neck, the person who is prone to have episodic migraine before and has an injury like this is way more prone to develop daily headache and daily neck-related headache than someone who isn't prone to have migraine before this type of injury occurs. So the next picture I want to show is what happens in post-traumatic headache. And this is something called the International Headache Society criteria. This talks about what you need to have if someone wants to use a diagnosis of chronic post-traumatic headache. And really this is kind of a complicated slide, but really the most important things is that someone has chronic post-traumatic headache if they have some degree of headache that lasts more than 3 months after a head trauma and have had a substantial amount of head injury. That's all you really need. This doesn't talk about where the pain is located. This doesn't talk about what type of migraine someone has. This just means that someone has headache and they've had a substantial amount of head trauma and it's lasted for more than 3 months. I'm going to go to this next slide here. And this one talks about acute post-traumatic headache. And this is the same concept. Really all that means is someone's had a substantial amount of head injury and their headache is between 7 days and 3 months. And we call that acute post-traumatic headache, meaning it just happened and they are into daily headache quite quickly from this. And whiplash can occur in car accidents, but whiplash can also occur if someone is holding their dog on a walk and the dog runs real quick and jerks on the leash. You can get whiplash if someone slips on the ice and jars themselves to gather themselves before they fall over. You can see whiplash if someone has a slip and fall injury. And you can see whiplash if someone's into car accidents or even physical assaults or if they've been shaken aggressively in times of domestic injury. Now here, the International Headache Society criteria gives us really very little diagnostic criteria to go by. If we talk about what's happened in this type of injury, the concept is that the nerves that surround the lining of the brain and the nerves that surround the neck are irritated from that motion, and they stimulate or they irritate not only the nerves in the top half of the neck, but also the nerves that go into the neck that are part of chronic migraine. So these folks develop neck pain, neck spasms sometimes, and also persistent headache. And the key to getting them better is to treat the neck symptoms in addition to the chronic headache. Now, one of the things I didn't include that I just should talk about for a minute is this concept of muscle spasm. So there's numerous muscles that are throughout the neck that are part of keeping our head in normal positions. And we use these muscles to look left and right, to look up and down, and they connect to the skull to various areas of the neck. There's a few muscles that are worthwhile identifying and highlighting. In the back of the neck, right where the neck and skull come together, there's several small muscle groups, and they've got a fancy name to them, but really we know them as the neck extensor muscles. The fancy name for those who are interested is a muscle called the rectus capitis posterior minor and its associated muscles. But this muscle is quite unique because it's designed to connect to the back of the skull to the back of the neck. And yet about 10% of the U.S. population has a variation where this muscle not only connects to the back of the skull and back of the neck, but it also connects to either the lining of the spinal cord itself, which is a very pain-sensitive structure, or it connects to the back of the lining of the brain in the skull, which is also a very pain-sensitive structure. So if someone goes into spasm of these muscles, let's say someone has a whiplash injury and their neck spasms as part of its healing mechanism, those muscles not only pull on the bones in the neck and pull on the back of the skull, they also pull on the lining of the brain, and they pull on the lining of the spinal cord for some individuals, and that generates a tremendous amount of chronic headache for them. And many times they say, I've got the spot in the back of my head, and man, is it sore, and everything I've done so far hasn't really helped it. And if someone has that issue and they've got this muscle that's spasmed, not much will help until attention's focused on that muscle. And that's a very easy way to help people, a very important way to help people who've had a whiplash injury or someone who's got a neck pain issue that's generating daily headache. So I'm going to go to this concept of depression and post-traumatic stress disorder. And I've got this picture up here which shows that people who have a head injury, and that's a TBI, stands for traumatic brain injury. People who've got a traumatic brain injury and chronic pain are very common to have depression, but indeed their pain is not related to depression. So what this means is if someone had a very severe head injury, they are likely to have depression, but if someone has a mild head injury, they're likely to have depression. And this also shows that if someone's had a mild head injury, they're more likely to have chronic pain compared to a moderate or severe head injury, which really just goes again to show that it's more important the type of person who has a neck issue or headache issue going in. If someone's prone to have migraine and they've got something bad that happens to their neck or head, they're more prone to have headache afterwards compared to people who aren't prone to have migraine. Now, what do you look for when you're examining someone? So let's say you see your doctor, you see your nurse, you see your provider in the clinic. What are they looking for when someone comes in with neck-related headache disorder? So the first thing we're looking for is cervical spine range of motion, which means can someone take their chin down to their chest and look all the way up to the ceiling as far as they can, moving in a nice smooth motion? And this is looking to make sure there's no signs of muscle spasm making the head not move correctly. The doctor's also looking to make sure it's a nice smooth motion. People who've got a lot of neck spasm have a ratcheting kind of stepwise upward movement of their neck, and that suggests there might be a muscle issue. Some people have got a bone problem where the bones in the neck won't let the neck extend the way it's supposed to. They can't look up to the ceiling because the bones are kind of jarred in place. And those people lift their chin up maybe an inch or two, but can't go all the way up like they're supposed to. And the next thing is looking left and right. Looking left and right gives the doctor an idea how well the neck joints move when they look left and right. And indeed, there's some neck joints we're going to talk about in a minute that are very important from a neck-related headache syndrome concept. The next thing your doctor might do is press on certain areas. that might press in the back of your skull, right where the neck and head come together. And that's where those important nerves are. We talked about them briefly, called the greater occipital nerves. But these nerves go out of the back of the skull, and they go up the back of the head. Many times, doctors will press back there to see just how sore someone is. Sometimes your doctor might press in the front of your eyes, and this is right in your eyebrow area. There's spots that they press on to see if those are sore too. Those are common areas of soreness if someone has chronic migraine, but also if they've got a neck problem, you can get pain that goes all the way to the front of the eye and makes the eyebrow itself achy and sore in certain areas. Your doctor may also look in the bottom of this slide now. Your doctor may also look at your eyeballs, making sure that the pupils move the way they're supposed to, making sure the back of the eyes have no signs of swelling, and making sure that the eyelids operate correctly. In this picture, the person has a droopy eyelid on that right side. The eyelid's kind of drooping down. It actually looks like the left because when you look straight at the person, it's the right eye that looks that way. But that droopy eyelid is actually a nervous system problem. That means that that eyelid's not getting enough signal from the brain to keep the eye open. And that muscle gets kind of weak and drops it down. And that nerve goes all the way from the brain down the neck, all the way back up the neck, and then into the eyeball. So if you have a neck issue, you can commonly irritate that nerve bundle, and people get a partial eyelid droop as part of their pain experience. So the next thing I'm going to show you, I jumped 2 slides forwards, but looking at neck symptoms that are common in migraine. So check this out. We know that if you look at plain migraine, and these are people who have not had an issue with neck-related headache disorder, 1 in 3 of those people will have neck pain as part of their plain migraine. So that as we've talked about already, there's pain nerves that go from the neck that go up into the brain that are part of migraine. There's also pain fibers that go from the brain down the neck that are also part of migraine. So plain migraine, you can get pain in the back of the head, you can get pain into the shoulders, you can get pain into the back of the neck itself, and that's all normal in migraine. And 1 in 3 people with plain migraine have some neck achiness or neck stiffness sometime during their migraine. The picture that I'm showing here are actually referral patterns, and those fancy numbers next to those C letters respond to areas of the neck, and that just shows that areas of the neck can give people pain into the head. So that top left-hand picture where the shaded areas in the back of the skull, that shows that people with neck-related problems at the C2-3 area, which is the top portion of the neck, can get pain in the back of the neck and pain in the back of the head also, which can therefore trigger or bring out chronic migraine in people. So this next one just talks about some of the pain-sensitive structures in the neck. And we've already talked about in the head what's pain-sensitive, but these ones look at the neck. So in the neck itself, the things called discs of the neck, those are those padded areas between the bones, those can generate pain by themselves. They've got pain fibers that wrap around those discs. So if someone has a bulging disc or a disc that protrudes backwards towards the spine and presses onto the spinal cord, that can generate pain. But there's also side joints of the neck. And these side joints of the neck are called cervical facets. And I'll get to those in a minute. But we know that the discs themselves can be pain sensitive, the side joints of the neck can be pain sensitive, and so can the nerve in the back of the head called the occipital nerve. Now this next picture talks about the occipital nerve itself. And so if you've irritated that nerve that comes from the neck, and this is a shaded picture showing the skull and the neck bones together, and on that first left-hand side picture, there's these spaghetti-like noodles of nerves coming up. Those are the occipital nerves that have been drawn into this picture. And those occipital nerves are kind of free-floating nerves that leave from the neck and go up the back of the head. On the picture towards the right, you can see that if someone rotates their head a bit and looks upwards, you can squish or compress that nerve. And that's where people get features of occipital neuralgia. That's pain in the back of the head, sometimes lightning bolt jabs and jolts in the back of the head, sometimes a tingly sensation of their scalp in the back, and that can generate daily migraine in people. And that's that occipital nerve itself. Again, that's a neck nerve. That's a C2 neck nerve that if it's irritated, turns on migraine for people. That position you see on the right-hand side of the picture is actually a very common position if someone's being hit by a fist, being punched in the face. That's also a very common position to be in if someone's looking in the rearview mirror when they're struck from behind in a car or truck. and that position can irritate these nerves and generate neck-related headache syndrome. So again, this is where the neck structures become pain sensitive, and that occipital nerve is a neck structure nerve, and it generates migraine headache because it turns on migraine because those nerves that we're seeing in this picture are directly connected to the nerves that generate migraine headache. So this next picture is kind of gross. This just shows you that that nerve actually leaves deep in the skull, and it goes through that meaty picture I've got pictured here through several different muscle groups before it goes to the back of the head. And I guess this is a bit too technical for to make a whole lot of sense out of it, but the bottom line is that if any of those muscles that are shown in this nasty picture are pressing on the nerve or pressing on the structures around the nerve, it can generate nerve pain and nerve irritability. And this nerve has to go through several different muscles and then cross through several different ligaments in the body before it goes in the back of the scalp. So neck spasm or muscle spasm in the back of the head can bring out neck-related headache by pressing on some of these structures. Here's another picture of that nerve, and again, just trying to show you that that nerve itself, and I know it's kind of hard to see what's going on in this picture, but that nerve itself has to cut through several different muscle groups before it goes up into the back of the scalp. And in there, I've got C1 and C2 labeled on that picture. Those are the neck bones. C1 is the highest neck bone to it, and C2, which is labeled just below in that picture, is the second highest neck bone. And this nerve comes right from that C2 area that wraps through some muscles up in the back of the scalp. And this is that neck-related headache concept. So what do you do about this one? So if someone has pain in that nerve bundle, you can do something called an occipital nerve block. And I've got this kind of picture on an anatomy model here. And indeed, you don't usually use that much medication. You don't usually use a needle that big if you're going to do this. But the concept is that if you inject numbing medicine right into the scalp, right where that needle is showing in the top picture, you can generate substantial headache benefit for people who have a neck-related headache problem. And the concept is quite simple. If you put numbing medicine on that nerve, it calms down not only that nerve, but the entire path in the neck and the entire path up into the brain that's part of chronic migraine. And I like to tell our patients this is very safe to do. This is just like when a dentist numbs a tooth before a dental procedure. Many times the same medications are used. It feels quite the same, meaning there's a pinch and there's a sting and burn for about 10 seconds or so, and that goes away. In this type of nerve injection, there's a numbness in the back of the scalp that lasts only for about 5 or 6 hours, and then that goes away. However, this can stop chronic cervicogenic headache in its tracks for some people, and the average length of headache benefit and neck pain benefit from doing this type of injection is about 3 to 6 weeks, and sometimes more than 3 months. This is very, very safe to do. When you inject numbing medicine into the scalp only, like that top picture is showing, you're nowhere near the brain, you're nowhere near the spinal cord, so it's very, very hard to have anything bad happen from this. It's just muscle and skin that you're putting this injection into, so you don't have to worry about things like stroke or having a problem in the neck after doing these injections. It's really just a scalp injection with the same types of medicines that dentists use before a dental procedure. On the picture on the bottom, this is what you don't want to have done, and that's where they actually put the needle into a straight direction. And then it's still done at times, but it's harder to know where that medicine goes. And then the safety may be a little bit different in those situations. So if someone's going to have an occipital nerve block done, I suggest the top picture. Let me show you what this looks like. I've got this picture just showing what people typically use for an occipital nerve block, and for those more technically interested, I've got the actual types of needles used and the actual types of medicines used, and those are variable depending on which doctor you're seeing for this. But here's what an occipital nerve block looks like. The first picture on the top left is someone in our clinic who's sitting for this nerve block, and we ask our patients to put their chin as close to the chest as they can do. We typically have a pillow in front, and they rest their forehead on top of a pillow. But for this picture, he was just sitting in this position for us. We then press and identify the area in the back of the scalp called the occipital notch. That little bump that's right there in the back of the scalp where this nerve exits and goes into the scalp itself. We then clean off the area with a topical cleaning agent, and then we inject numbing medicine right into that spot to see if that can shut off headache. This is very safe to do, and people who do these nerve blocks frequently can usually do this in less than 1 minute. This gentleman, if the injection is done appropriately and what you'd expect to see, will experience a numbness in the back of his scalp right where the injection is. It sometimes goes all the way to the top of his head. That numbness lasts 5 hours or so, but again, the average length of benefit is about 6 weeks or so, and many times it can stop daily cervicogenic headache in its tracks. And one of the most effective ways to improve cervicogenic headache. This next picture just shows you that that nerve I'm talking about has a bunch of variations to it. You can have that nerve being just the occipital nerve. It can make the lesser occipital nerve, which provides a different area of pain sensation in the back of the scalp, or it can provide pain to the front of the face through this nerve bundle called the great auricular nerve. And that's more than you need to know, but mostly I have this picture just to show you that that nerve has some variability. So if someone has a nerve block like this done, they might get numbness in the back of their scalp, they might get numbness towards their ear, or very rarely numbness onto the ear into the front of the face. And all those are safe outcomes from this. It just means that someone has spread of medicine to a different nerve, or the nerve connects to an area it doesn't usually connect to. And again, all very, very safe from an injection standpoint. Now the next thing is really the most important piece. If you have one piece of information to leave from tonight, it's this concept of cervical facet pain. So let's look at that top right-hand picture. In this picture, you can see the skull and the neck is extended, meaning that the head is shifted backwards and looking upwards. And what that does, if you put that kind of strain into the neck, is it makes the side joints of the neck, not where the discs are, but onto the sides. And that's what I got in that lower picture. Those side joints can get irritated or bruised or sore. And on the bottom left-hand picture, you can see there's the spine itself, which are the white bones. Then you've got these little joints off to the side of those bones. That's where that yellow spaghetti-looking bundle of nerves is. And that area where the two bones come together is called the cervical facet. And those are the side joints of the neck. So for those listening in who have a neck issue, you may find yourself cracking your neck, and that's where people look left and right, and you hear that pop, 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 pop. What happens is people are cracking open, making those joints expand more than the body is used to, and that's that popping sound. Those are those side joints of the neck. That's why someone cracks one side and then the other, because these are side joints. And they can never crack the neck more than 7 pops at a time, because that's the number of joints you have in your neck. So it turns out that those are very, very pain-sensitive side joints of the neck. These have nothing to do with the discs in the front of the neck. These are all side joints of the neck. And if those are bruised or sore, those are very much pain-sensitive, and they send pain information through those same nerves that we talked about in the beginning of this discussion. Meaning those same nerves that bring pain from the neck up into the brain as part of migraine are the ones that these ones connect to. So if the side joints of the neck are painful and sore, it turns on the same nerve bundle as if someone's having a plain migraine. They usually describe that they've got this achiness right where the neck and head comes together, usually off to one side. There might be some spots on the side of the neck that they can press on that are sore more than the other side is. And if that irritates it enough, it turns on daily migraine. And these people have neck achiness, and then they've got migraine that usually favors one side over the other, but it can be on both sides. And they've got some degree of pain all the time, but clearly things like looking up or down or left to right might worsen their pain. Things like driving in a car, even coming to the doctor's appointment itself can bring out pain, because they have to look at their blind spot, and they've got to drive in a car, which makes their neck motion more increased and brings out irritability. So the bottom line here is that those side joints of the neck, especially the top half of the neck, those side joints of the neck are very pain sensitive, and the pain fiber there connects to the same areas of the brain that generate headache. So I've got some more pictures of this. Here's a picture of the side of the neck, and what I've done in that yellow dotted line on the top picture is shown what a nice, normal, healthy-looking facet joint looks like, and then on the bottom picture, it's what an arthritic facet joint looks like. So in that top picture, where there's dotted yellow to it, that shows you nice, clear lining of bone between the two joints. And the fluid inside there is very happy and not bothered at all. In that bottom picture, right where the arrow is, you can see that line between the two bones is kind of murky and lumpy and looks kind of not as clean and not as healthy. And that's arthritis. That's showing people arthritis of the neck joints. And in this case, it's the high neck joint, which is the C2-3 neck joint. If someone has arthritis there from a car accident before, or if they have rheumatoid arthritis, or if they've had cervical trauma, they get arthritis in the top half of the neck and that left on the side of the neck, that'll generate daily migraine in some people, especially if someone's prone to have migraine in the first place. So I'm going to come forward here. When a doctor does a picture of your neck, this is what they're looking at. So I've got on the right-hand side in this picture, you've got a kind of a salami cut right down the middle of someone's neck. And it's tough to see, and I don't have a way to point this out for those listening at home, but you can see how that clear lining of white that starts in the top of the head and comes down the neck is narrowed and squished down, and it becomes not as clear, and that's arthritis of the neck doing that. On the picture on the left, you can see that white puffiness around the side of the neck, and that's markings of inflammation, showing that someone's got arthritis and inflammation on that side joint of the spine in this picture. And then very hard to see on this picture, and this is unfortunately a limitation to this presentation I'm providing. The slides didn't come through the way I wanted it to. This just shows people that even on MRIs of the neck, you can see arthritis affecting these side joints. And many times that becomes an explanation for someone who's got daily headache after trauma or daily headache after they've irritated their neck somehow. And it becomes a therapeutic option for people because you can numb those neck joints just like you can numb the nerve in the back of the scalp, something called a cervical facet block. So I've got here some medications that are commonly used for neck-related headache disorders. And before I talk about these a bit, I want to make sure people know that most medications that help prevent migraine can be effective for neck-related headache disorders, because neck-related headache disorders, things called cervicogenic headache, is really plain migraine that has been turned on by neck structures. I've highlighted some here with the circles around them because these ones in our clinic seem to be more effective for people with neck-related headache disorder compared to people who use other medications. So duloxetine is one listed up there. That's actually an antidepressant medicine that actually works for pain also. Then I've got the ones listed on the other areas, like things like topiramate and gabapentin and pregabalin. Gabapentin and pregabalin are medicines designed to treat nerve pain, but they also have some benefits deep in the brain for people who've got chronic pain. And your doctors and providers know a lot about these medications, how to use them effectively, and to decide whether these therapies are right for you, for those who are listening in, if you have a neck-related headache disorder. This next picture is showing just that you can numb the joints of the neck. So I talked a bit about those side joints of the neck and that those can get bruised or arthritic. This is a picture showing that you can actually numb the joints on the side of the neck. And again, this is actually quite safe to do. For people who do these all the time, you can direct the needle towards the joints that are arthritic or sore and numb them. And indeed, if someone does great from a numbing injection, but it doesn't last a long time, you can do the same thing, but instead of numbing the nerves around the neck joints on the side there, you can actually heat them up. And when you heat them up, that lasts for an average of 9 months to a year, sometimes even longer than that. So our young, healthy folks who've got neck-related headache from a car accident or from a physical assault, meaning that they've irritated the top portions of the neck that are generating chronic migraine, do very well with these types of injections and procedures. It allows them to have a dramatic reduction of headache many times, a dramatic reduction of neck pain many times, and to be on very few medications compared to if they haven't had these procedures done. Last thing I need to talk about before I open up for questions is this concept of neurostimulation. And because the nerves of the neck are very easy to get to, some clinics, including ours at University of Michigan, provide neurostimulation treatments for the right patient who hasn't done well from your typical therapies. And really what this means is you actually put wire electrodes under the skin and see if you irritate those nerves with electrode stimulation, and if that irritation distracts the nerves from pain, you can reduce headache or neck pain by using these things. And usually you put them in under the skin with everything else outside the skin first, and you wait about a week and see how well they do. And if someone does really well with that, you can actually implant them, where you put them under the skin, and they remain under the skin where you can't see them unless you press on them. And the patient who has this thing can turn on that device or turn off the device. They can make it escalate in how strong it is to try and turn off nerve pain coming from the neck. And that's called a peripheral stimulator or an occipital nerve stimulator, as this guy has in this picture. So that's part of what I wanted to cover for today. And I'd like to open it up now for any questions out there from those listening in.
All right. Thank you, Dr. Wade. Our first question comes from Anne. She'd like to know if there's a relationship between cervical osteoarthritis and cervicogenic headache. The headaches that she are experiencing are becoming more frequent as her arthritis increases, and she doesn't know that there's anything she can do about the arthritis since she cannot take NSAIDs. Do you have any suggestions?
Right, and I advise you to discuss this with your treating provider. In general, when we see patients who have arthritis of the neck and they've got frequent headache, we almost always think cervicogenic headache. So yes, I think there's a strong relationship to this. Osteoarthritis kind of implies wear and tear over time. Other arthritis types like rheumatoid arthritis classically love the high neck and can generate headache for even young, healthy people who've got this rheumatoid arthritis syndrome. So I do think that that's quite a strong possibility. If someone has osteoarthritis of the neck, it could very easily be generating or worsening underlying headache. If someone can't take anti-inflammation medications, there's a whole host of options available for treatment. The first thing that we would consider if someone's being seen in our practice for this is to consider doing nerve blocks, like the occipital nerve block or sometimes something called a cervical facet block. And as the pictures I just got done showing would indicate, that's where you put numbing medicine over the nerves where the arthritis is. And it sounds crazy, it sounds weird, but it's actually very safe to do. And if someone responds well, they need very few medications to help with this issue. And they do most of their work with these numbing injections. But if someone's looking at other medications, medicines that work on nerves around the spine and nerves that generate headache up into the spine are medicines like gabapentin or pregabalin, or sometimes medications like duloxetine. And those are brand name medicine, or the brand name equivalents are things like Neurontin and Lyrica, or medicines like Cymbalta, to try and reduce nerve irritability, especially in this area where it can be very pain sensitive. Lastly, in our clinic, we use topical gels. And no, I don't think a topical medicine or something you rub into the skin is going to get all the way down to the spine. But if someone is irritated, the nerves that go into the back of the scalp, topical medicines that are rubbed into the skin, can actually get to the nerve, because that nerve in the back of the scalp is only a couple millimeters underneath the skin. So we rub in medicines that contain lidocaine or NSAID class medicines that don't get into the bloodstream called ketoprofen, and then sometimes even a nerve medicine put into there, something like gabapentin. That's a great question, Ann, and I'd encourage you to talk to your doctor about these options because that might be very effective for you. Is there other questions out there?
Yes. Next question from Candace. She'd like to know if there are bone spurs on the side joint, what occurs?
What a great question, Candace. So if people have bone spurs on those side joints, those joints that we call cervical facet joints, that actually irritates the side pain fibers. And there's a fancy word for them called medial branches. But really what that means is that the body has pain-sensitive nerves that surround the side joints of the neck, just like your finger joints. So if you can imagine, your finger joints are pain-sensitive. And if you've ever jammed your fingers, or if you've ever had someone hurt the joints of your fingers, it hurts really bad. And it can take a long time for that pain to calm down again. So if someone has bone spurs on the side joints of the neck, they typically have trouble with pain on those side areas of the neck. They many times will find that their neck doesn't look left or right or up and down as well as they would like it to. Maybe it worsens their pain to look up and down and left and right. And they typically have headache if it's affecting the neck and head. They have headache in the back of the head that tends to move forwards and become either all on one side or become the entire head. But many times they have up and down headache, but they've got this background persistent achiness, which is usually in the back of the neck and over to one side. And so it's very, very pain sensitive to move. And those people respond to treatments for neck-related headache disorder, for cervicogenic headache, much better than they do plain migraine.
Our next question comes from Diane. She has a loved one who has had TBI 3 years ago and suffers from horrible headaches every day. Last year, they said she has cervicogenic headaches. She has had nerve blocks twice, and at each time it made it much worse. How does one proceed when we believe the headaches are coming from the neck? Movement seems to be the worst factor for her. Are all cervicogenic headaches migraines? And they've tried lots of medications for migraine, but nothing seems to work.
I understand the question. And so let's break it down to a few different pieces. So first of all, is all neck-related headache migraine? And indeed, the nerves of the neck can turn on underlying migraine, but some people have chronic chronic headache that doesn't fulfill all the criteria of migraine. So you don't have to have all the features of migraine to have a neck-related headache disorder. You can have just pain without light and sound sensitivity, without nausea, and without some of the other characteristics of migraine. But more commonly, if someone does have enough persistence of headache, those neck structures will turn on all the other features of migraine. In this situation, if someone's tried treatments for cervicogenic headache, and I'm going to assume that they've tried your typical medicines and they've tried nerve blocks, the next thing we would consider if we were caring for that patient in our practice is to look for muscle spasms right where the head and neck comes together. And specifically, the group of neck muscles called the neck extensors, and even more specifically, which is way more than people want to know at home, I guess, but a muscle group called the rectus capitis posterior minor. And if that muscle is irritated, people get spasms in that area where it hurts to look up and down, sometimes left and right. It makes the neck get spasmed where it can't move in certain positions at all sometimes, and very, very pain sensitive to press on. Nerve blocks, like cervical facets or occipital nerve blocks, don't go into this region. And these patients do well with either trigger point injections, which is numbing medicine to that muscle, or they do well with Botox to that area, or they do well with using medications that are typically muscle relaxant focused or anti-inflammation focused. And I'd encourage them to discuss the providers those types of treatment options.
So our next question comes from Paul. Would Botox injections in the cervical area have any value?
What a great question, Paul. And so let's look at that in a few ways. We know that botulinum toxin A, which is known as Botox, has been approved for chronic migraine, and that happened about 2.5 years ago. On a separate issue, botulinum toxin A and other medicines like it have been used for neck spasm issues, but they're focusing on different concepts and different treatments. So indeed, if someone has enough chronic migraine burden from their neck, they've got chronic migraine as the source of that, Botox and botulinum toxin A can be very effective for that. If someone has a problem with their neck generating headache, sometimes Botox can help, but sometimes it can worsen headache or not change headache because Botox doesn't focus on the neck mechanics or neck nerve sensitivities as much as it does chronic migraine. If someone has a spasm issue in the neck and they get cervical dystonia, this is where the doctor doesn't do a general pattern throughout the entire head and scalp and shoulders. This is where they choose certain neck muscles to focus their medicines on, many times with an EMG machine to focus on which muscles to go on. That can be very helpful if someone has a neck spasm issue. But in general, Botox can be helpful for neck-related migraine, but not because of the neck structures uniquely, but more because it shuts off the chronic headache component to it.
It looks like our next question comes from Debbie. What measures can a patient take to reduce neck-related headaches, aside from medical procedures and pharmaceuticals?
Yeah, what a great concept. And in our clinic, we're very big on naturopathic type treatments. And one of our most effective treatments is to use a vitamin supplement of magnesium. But not all magnesiums are the same. And I feel quite strongly about this. Magnesium oxide, typically at 500 milligrams a day, or magnesium glycinate, typically at 400 milligrams a day, works as a normal muscle relaxant as well as a way to shut off migraine sensitivity. These are usually available at any pharmacy, and the cost to be on these per month is about $5 to $10, so not super expensive. The only main side effect that people have to be alerted for on magnesium is diarrhea, which is occurring in less than 1 in 20 people, not because they feel sick and have diarrhea, but because their body can't absorb the magnesium. Magnesium is in lots of multivitamins, but unfortunately most multivitamins, the magnesium is worthless or not usable because of how it's absorbed. So in our clinic, if someone's on a multivitamin that has magnesium, we still add in the same strength of magnesium as a supplement. Again, that's magnesium oxide at 500 milligrams a day or magnesium glycinate, 400 milligrams a day. Both of those you'd want to talk to your physician before starting. The other thing is that there's some other vitamins that are worthwhile mentioning for neck-related headache disorder. There's a vitamin called Boswellia, B-O-S-W-E-I-L-L-A, and Boswellia is the body's natural natural anti-inflammation vitamin, as well as many times we use things like glucosamine to reduce some of the neck joint irritability. But those vitamins have been very helpful. The next thing is that physical therapy or other manual therapies, including chiropractic, can be very helpful in reducing neck-related headache issues, especially when that provider focuses on the high neck area where the neck and head come together. You can tremendously reduce the spasm of muscles in that area, and you can reduce nerve irritability in that area with a skilled provider working there. And lastly, moist heat is very effective. If we're going to ask someone to use moist heat in our practice, we would ask them to take a clean sock or a new sock, put uncooked rice into a microwave and tie the end, and then you stick it in a microwave with a cup of water and let it go for a good 3 or 4 minutes. The water in the microwave makes the vapor absorb from the water into that rice sack, and then you wear it around your neck. Most of the time our patients put it in the high neck area, so they kind of have it touching the back of their scalp, and they wear it to see if that moist heat will make the muscles relax and therefore reduce some of the irritability in those areas. Good question.
Thank you.
Other questions out there?
Yes, our next question comes from Heather. Can chiropractic treatment help occipital neuralgia, and if so, how?
Another very good question. And I think chiropractic can be very effective for neck-related headache disorders in general, as well as for occipital neuralgia. Now, I'm a neurologist by training and a headache specialist, and so I typically speak a different language than our fellow chiropractors in our community. But their focus is to reduce strain and irritability of the high cervical spine, and they've got different ways of doing that. If someone has occipital neuralgia, that implies that that nerve that begins in the top portion of the neck, that we call C2, is irritated either from the neck bones itself or from the way the nerve has gone through a bunch of muscles or in the scalp itself. And anything you can do to reduce that irritability, which means treating muscle spasms, which means making sure spine alignment is open enough to let the nerve through, and making sure the tissues in the back of the scalp are as healthy as they can be, can help occipital neuralgia. So I think any manual therapy, including chiropractic, can be very helpful for treating occipital neuralgia. We typically avoid our patients having the cracking maneuvers of the high cervical spine, but I think if that's done by appropriate clinicians, it's still safe to do. We worry about the irritability of the neck joints with frequent cracking episodes, and there's a very, very rare chance of getting a blood vessel issue in that done, but that is just as rare as if someone's riding a roller coaster or if someone's having sex, you can irritate that same blood vessel. So I think in general, chiropractic work is quite safe for those who've got neck-related headache disorders and occipital neuralgia.
Our next question comes from Barbara. Should one have an MRI first before doing an occipital nerve block?
No, most of the time in our practice, we reserve occipital nerve blocks for those people who've got some degree of headache or neck pain on a daily basis. And in our clinic, if someone has headache or neck pain issues on a daily basis, we'd like to have one high-quality MRI and neck MRI if they've got a neck problem on done sometime in the recent past. And the reason why isn't because occipital nerve blocks are unsafe. And I can't think of too many reasons why someone wouldn't want to do an occipital nerve block because of an MRI finding. But more importantly, there are certain ways to change your therapy. If someone has a neck MRI and they find that they've got something called a Chiari malformation, where the brain's a bit too low and protrudes through the skull and irritates the brain, those are things you can treat with occipital nerve blocks, but other treatments. If someone has a congenital fusion, and that's where when the bones are developing at birth, or even after time, if someone has enough arthritis in the neck, the bones kind of form together and they don't have a facet joint on the side, that implies pain can be generated above and below that area. And your targets wouldn't be just an occipital nerve block. We'll be looking at those cervical areas that are having the partial fusion next to it. So it changes your treatment. But if someone doesn't have an MRI done of the brain or neck and they choose to do an occipital nerve block, it's almost always safe to do that.
Our next question is from John. He'd like to know when he strains his neck muscles through exercise such as yard work, he seems to have a migraine. He wants to know if that's logical and if neck muscle strains can trigger a migraine.
Yeah, and that's a very good question. So there's two ways to look at that. The first way is if John has plain migraine headache, meaning nothing wrong with the neck, nothing wrong with the muscles in the neck. And if someone's raking leaves or doing other physical activity, there's a fair amount of neck motion that's taking place there. Because the normal nerves of migraine are connected to the neck, any extra activity to the neck, any extra activity to those muscles can irritate or turn on migraine for some people. However, more common in our practice, if someone has frequent headache that's triggered by that type of activity, we look for signs of a neck-related headache issue. So if that person has an issue with the top joints of the neck that are a bit more sensitive, a bit more arthritic, or a bit more irritated, then that's going to bring up migraine pretty easily. Things like raking leaves, pulling a lawnmower rope to get it started, bending over, crouching down, picking up things. Those are all things that work the neck muscles and the neck regions quite well. So if that's a common occurrence and someone's had not great success with treating the plain migraine, then I'd look at the neck in those areas. Next question out there.
The next question comes from Michelle. She has chronic migraines and lots of neck pain. Her recent MRI of the neck and head were normal. Does that necessarily mean there is no inflammation or arthritis? She's also had facet injections several times, and they didn't help.
Yeah, so that's a very good question. I didn't have a chance to cover that in today's lecture because I was pinched for time and didn't want to cover too much at once. But in general, neck MRI studies are very good at finding problems with the discs, which are in the front of the neck, and they're actually not very good, or at least they're not, their focus isn't to look at the side joints, these areas called cervical facets. So commonly we find people who've got a lot of facet irritation or facet arthritis, and the report is completely normal. Radiologists are trained to focus on the central structure, so they look at the spinal cord, they look at these things called cervical discs, but they very rarely comment on the side joints, which is called cervical facets. So quite common to have some neck symptoms or even sometimes advanced neck arthritis of the side joints and have a report that sounds quite normal. The next thing is if someone's had facet blocks and not done well, does that exclude them having a neck issue or neck arthritis? And that's not always the case. Facet blocks do not always work, and someone could have a muscle issue, someone could have a different facet than what was worked on, or to even make things more complicated, and something I didn't cover in too much detail, is that there's a takeoff from the cervical facet that's not always done in facet blocks for neck-related headache disorders. That's a nerve called the third occipital nerve. And the third occipital nerve starts kind of lower in the neck. It's at this area called C3-4. And that nerve goes through the muscles in the neck up like a stripe up the back of the head, almost like a mohawk stripe. And that nerve is commonly not done in cervical facet blocks. So patients with a lot of pain like a stripe in the back of the head will have cervical facets. And if the doctor doing the facet blocks doesn't include that nerve, they're not going to have any headache benefit to it. I think we have time for a couple more questions, and I think we'll close up the webinar. So a few more questions out there?
Sure. What is your opinion of cranial sacral manipulation for cervicogenic headaches? Comes from Shirley.
Hi, Shirley. You know, I'm kind of biased on this one. As an osteopathic physician, I'm very aware of cranial sacral therapy. And for those who haven't heard that phrase, that's the concept that the normal fluid that lines the brain and spinal cord, that the brain kind of floats in, has a pulsing mechanism to it, and that if someone is trained in how to do a very specialized type of hands-on therapy, they can make that fluid flow operate better and more smoothly for the body and therefore reduce headache. So I think cranial sacral therapy can be very effective when it's done by someone who knows how to do it very well and in the right person, so that it can be great for some people, and I would encourage cranial sacral therapy for cervicogenic headache. However, I've seen it less effective for plain migraine, and I've seen it less effective for people who've got other types of headache syndromes. Cervicogenic headache is one of the few ones that I think it's very effective for and absolutely safe to have done. So really, if you have a good, talented provider who's able to do that service, I think it's worthwhile thinking about if someone has cervicogenic headache.
All right, looks like the last question we will get to tonight is from Anne, and she'd like to know what kind of pillow is recommended for those who have cervicogenic migraines.
Well, that's funny, Anne, because a lot of my patients describe, when they come to our clinic and they describe their headache, they say, I've got this very ornate way of setting up my pillows when I go to sleep. So I've got to twist this pillow one way, I've got to put another pillow behind me, I've got to lie on my side, I've got to have a blanket rolled up this way. And really all that pillow behavior is really describing ways to protect the neck while they sleep. And when someone sleeps, the neck is unprotected, meaning that neck can roll up, it can twist, it can turn, it can do all kinds of things. And people try to protect against that by having this ornate way of organizing their pillows and their bedding before they go to sleep. It turns out that I don't have a specific pillow to recommend for people. The ones that my physical therapist colleagues tell me work the best are ones that offer some degree of firm support and ones that go underneath the head to support the neck in an upwards fashion, and to avoid the ones that are pointy and that press in certain areas of the neck itself to try and relieve pressure. But I hate to say this, my experience has been really hit or miss with this. And I've got some people who invest a whole lot of money in very fancy pillows and are not satisfied. And I've got other people who buy a very simple pillow and get it just right, and they feel very comfortable with this. So the bottom line is I don't have a very specific recommendation for that. If you're working with a physician or a physical therapist, I would ask them their opinion because they can assess you and figure out if there's a specific match for your neck issue and the pillow.
All right, looks like that's all the
So
time we
that's
have.
the last of the time that we have tonight. Go ahead.
I'd like to thank everyone for joining us this evening, especially you, Dr. Cooper. Thank you for joining us. I'd like to apologize again for the technical difficulties, and sorry that we couldn't get to all the questions this evening.
Thank you all for your time tonight. Everyone have a very good night.